delivery in developing countries. It is my great pleasure to introduce Heidi McAnnally-Linz, who will be moderating this panel, and she will introduce the panelists. Heidi is the Deputy Director at the MacMillan Center for International and Area Studies at Yale. That's the center where YRISE is housed. She leads strategy, programs, and communication in this role. She joined the MacMillan Center after 10 years at Innovations for Poverty Action, where she led policy and external relations. And in this leadership role, she built and led a global policy and external relations team of more than 35 people in 12 countries. And it's particularly nice to have Heidi and the team, the Mask Norm team, on stage. We all worked very closely. I think that was most of my 2021 with Mushfiq as well, Mushfiq. In overseeing not just the original research, but very exciting in terms of the outreach and scale-up work. And that's something this panel is actually going to talk about. So take it over, Heidi.
Can you hear me? Oh, there we go. And as Neela said, this is actually the first time we're meeting some of these folks in person. So we realized when we showed up today that we hadn't seen each other in person. We didn't really know how to pronounce each other's last names. So as I introduced the rest of the panel, this is a panel on how you might scale and deliver some of the COVID mitigation tools like masks and vaccines, and what we learned about doing that in a crisis together. And kind of some of the lessons for the future. Oh, hi, Ashley. So Ashley Styczynski is our first panelist, and she's an adjunct clinical professor in the Division of Infectious Diseases and Geographic Medicine, as well as a medical officer in the International Infection Control Program at the CDC. She did her infectious disease fellowship at Stanford and also spent a couple years in the Epidemic Intelligence Service at the CDC. And she's done a lot of work on various outbreaks, including Zika, rabies, antimicrobial resistance, and now transmission of COVID-19. Our second panelist is going to be Laura Kwong, and she's going to share a little bit about the results from the mask research that we did together. She's an assistant professor in the Division of Environmental Health Sciences at UC Berkeley School of Public Health. And she uses human-centered design principles to develop interventions that address public health issues in low-income countries in particular. And she was a critical part of this team and has worked all over the world and has been multiple times in Bangladesh since the start of this project. And joining us also online, Asif Saleh is the executive director of BRAC Bangladesh. It's for those of you who don't know BRAC, I believe it's considered the world's largest NGO, and it's based in Bangladesh. And prior to that, he played various roles at BRAC, but also was in the government and the Prime Minister's office in Bangladesh, and also spent 12 years at Goldman Sachs, and has been a longtime collaborator of this team. And then finally, Jason Abaluck is an associate professor of economics in the Yale School of Management, and his work kind of lies at this intersection of behavioral economics, health economics, and industrial organization, and that was kind of the role he played on this team as well. And with that, I'm going to let Ashley kick us off with a little bit of framing of the work and why even today, here, it still matters.
All right, are you seeing my slides?
Yes.
Okay, great. So welcome everyone today, and I'm just grateful to be here virtually to even be able to share a little bit about the thinking that informed our design and that came from the design of our study. Of course, at the time that we were putting this together, vaccines were still a long ways away, and we all had visions that they would one day be available and represent the end game for the pandemic. And here we are now a year and a half into it, and we have vaccines. We have quite a few very effective vaccines, and yet the pandemic isn't over. And so I asked this question just to say, are vaccines the end game? And I would pose that they are, yes, part of the end game, but perhaps not the whole story. And so why is it that I am proposing this? And I think one of the things that we've clearly come to understand is that we need a multi-pronged global strategy if we're going to manage COVID and keep people safe effectively. Of course, it's without a doubt that we know that vaccines are the most effective strategy we have against COVID. And so in no way am I trying to diminish that fact, that they still continue to be a vital aspect of our fight against COVID-19. And we need to continue pushing to make access to them readily available all over the world. But I also just want to highlight that vaccines are not 100% effective, that they by themselves will not signify the end of SARS-CoV-2. And the reason for that is that while many of these vaccines are very highly effective, not even the best is 100% effective at preventing infection. And that's just the nature of vaccines and the nature of human biology. So even if you have a vaccine, you are not guaranteed to be protected from infection. We also know that there are many vaccines around the world that have had diminishing rates of protection as we've seen new variants. And so we will always be sort of a step behind trying to play catch up to these variants and to identify new vaccination strategies. And so the virus will continue to be one step ahead of where we are with vaccines. It just takes time to develop this technology. Also, we've learned very unfortunately that these vaccines, while very good at preventing serious consequences of the infection, often do not block transmission completely, such that people who are shedding the virus, people who are vaccinated can continue shedding the virus and passing it along to other people, whether or not they have symptoms. And this is pretty dramatic, has pretty dramatic effects when it comes to thinking about community transmission. And so this continues to be a gap in the protection offered by vaccines. We also know that even if we had a perfect vaccine, that we wouldn't be able to get 100% of the population vaccinated. And that's because there will continue to be pockets within the population who may have anti-vaccine sentiments, and that this has emerged long before COVID-19 was on the stage and is not something we're likely going to be able to fix during this pandemic. And of course, there are many things that go into contributing to that, but we know that these pockets of people tend to occur together, which allows these communities to continue to support transmission within their unvaccinated communities. We also know that vaccines are hard. They're hard to get into the arms of people. And why is that? I know that earlier today, people have been talking about many of the challenges, whether it's governments being willing to donate them, governments being able to receive them, international shipping logistics, cold chain logistics, in the field logistics, trust within communities. So it's not something that we can snap our fingers and everybody has a vaccine and is well protected. So this is a tool that needs to be part of our long-term strategy, but isn't unfortunately something that can be done in the immediate time period. And we know that the vaccines that we have are effective at preventing some of the severe consequences of the existing strains that we have circulating. What we don't know is what's ahead, that how the virus will continue to evolve, particularly among unvaccinated and undervaccinated communities, in a way that may make these vaccines less effective in the future. And fortunately, we've seen that even as the effectiveness against preventing transmission has waned, that these vaccines have continued to be effective against the most serious consequences, but that may not always be the case. So again, vaccines are important in the long-term strategy, but there remain significant gaps about what they can and cannot offer. And so what I would say from that is that masks are an essential adjunct. And I think this is something that we've come to see as we've understood what various prevention strategies do offer and don't offer. And why is it that they remain essential, even in an era when we do have vaccines? And well, one of the things that we know about masks is that they do prevent transmission. They may not be 100%, but we know that they play a substantial role in reducing viral exposure between individuals, particularly when both of those individuals are wearing masks. We also know that compared to vaccines, masks are relatively accessible and affordable in most contexts. So for example, even as we were starting our study, we did some observation in Bangladesh early in the pandemic at around the time they were issuing mask mandates. And even though Bangladesh is a LMIC country, low and middle income country, that a lot of people, over 70% of people, were able to wear masks, access masks. So, you know, for a few cents, you could buy one on the street that was reasonably effective. And so this is a tool that can be taken to scale relatively cost effectively, given the low cost of individual masks and how those costs have even come down over the course of the pandemic as manufacturing has been able to ramp up. We also know that mask use can be rapidly up or down regulated in response to changing epidemiology, that it can be something quickly, a quick on, a quick off, as we see different parameters changing in the population, whether it's a rise in cases, a rise in hospitalizations, or as cases are decreasing, we can remove things like mask requirements. And so it is a tool that's much more responsive than vaccines are. We also know that masks then can be a useful bridge to vaccination, which is what they were initially for populations all around the world. But even as there are many under-vaccinated populations, they continue to be able to serve this purpose. And even as new variants arise and vaccines maybe offer less protection or to high-risk individuals, they can continue to bridge us until we have perhaps a more universally effective vaccine. And we know that masks do not discriminate in the way that vaccines do, that they offer protection against even emerging variants that we haven't yet identified. And so this is why that masks, it's not an either or strategy where it's vaccines or masks, that masks can continue to fill some of the gaps that vaccines cannot. But we also have to acknowledge that masks are only effective as our ability to enforce the wearing of them. And that if this is going to be a tool in the toolbox for dealing with COVID going forward, countries need an effective strategy for how to implement mask use. What will make people wear masks, particularly in societies where you don't have a very strong government, especially more Western-oriented societies where you can't enforce a lot of these policies in a very authoritarian way. So how can you get the population to buy into this and to incentivize this and encourage mask use in real time? And then we know that not all masks are created equal. There's everything available on the market from a single layer homemade cloth mask to an N95. And so identifying what is going to be part of that masking strategy and understanding how much protection you're going to get from the various masks is an important part of the equation as well. And we know that they vary greatly in their different levels of protection just in laboratory studies. So understanding that on a population level is really critical to know how much you can be relying on masks. And then we know that not all mask wearers are created equal either. So just as there will be people who will choose not to get vaccinated, we know that human behavior also affects mask use behavior. So whether that's wearing the mask correctly or even being willing to wear a mask at all, these are pockets of the population that still have to be included in the considerations about different types of strategies. And then when we are thinking about masks and are they just relevant until this pandemic is over? The answer to that is no. I think if anything, this pandemic has shown us that this is one tool that we can continue to utilize, that we can help society to continue operating, institutions continue operating in the midst of these outbreaks, if we can also ensure that there's high level of mask usage. And so even as we deal with future outbreaks, be it pandemic influenza or measles outbreaks or tuberculosis, that masks can continue to be a very useful tool on the community level, which I think it was unknown whether that could be done before the COVID-19 pandemic, but now we've become so familiar and comfortable with this as a strategy that we realize even at a community level that masks can be highly effective. So leading into sort of what some of the motivation was then for our study was understanding that vital question of, okay, if masks are an essential tool, how can we rapidly increase mask wearing when there are spikes in circulation of SARS-CoV-2, and how can we use that to our advantage? And then a second question was, how much does mask wearing reduce COVID-19 in a real world setting? We know that they offer a certain degree of filtration efficiency, but what does that look like in a population level? And then finally, the third question is, do surgical masks and cloth masks differ in their effectiveness? And if so, by how much? And does that affect what kind of policies we should put forward as we're thinking about how to utilize masks? And so with that, I will turn it over to my colleague, Layla, to continue highlighting some of the various aspects of the study that we did.
There would be maybe an opportunity to increase mask wearing back up again, right? If we had started out at 90%, it's hard to go up from 90%. So the fact that it was lower indicated there was options here. And because we had really strong local capacity, not only do we have Mushvik and a lot of Mushvik's collaborators, but we had really strong implementing partners that could advocate for and implement the process that we designed. So what we did was develop a model that we deemed NORM. And NORM stands for no cost distribution of masks that were door to door. We also had offering information while those masks were being distributed to let people know why masking was important. Very importantly, we did reinforcement. So after we distributed masks at the household, we had people in the community maybe tapping you on the shoulder if you weren't wearing a mask and say, hey, we know you have a mask because we just gave you one at your household, but I see you're not wearing it. Could you go home and get it? Or did you forget one? I have another one that I can give you if you promise to wear it. We also use community leaders, religious and political leaders, to do modeling of mask wearing behavior. And this study was conducted in 2021. We first did a pilot of some of these interventions. We did a second pilot because we really believe that iteration and constant monitoring improvement is really important. And then we implemented the intervention in November of 2021, and it continued on. During this time period, we had very low rates of COVID infection. And so we continued the study for a number of months to sort of accumulate those infections over time. We were right before that large peak that you see over there. So the sample size was a tricky calculation in the pandemic. What we found in our first stage results is that our intervention, this offering masks, offering information, reinforcement, and using role modeling, increased mask wearing from 13 to 42%. That's about triple the usage. We were also able to sustain this mask usage even after the intervention. So we went back 3 months after the intervention, and there was really high uptake still. We found that masks, unlike some concerns, they didn't reduce physical distancing, but in fact, they increased physical distancing, probably because people were more salient of the risks of COVID. We used reusable surgical masks. So on here it says, like, wash me and reuse me. And we found that they were as likely to be worn as cloth masks, which was a good sign when we're thinking about future recommendations. And we also found that in-person reinforcement was very important. So through a very creative set of cross randomizations at the village level and the household level, where we looked at text messages, signage, verbal commitments, incentives, we found that a number of different strategies were not necessary to increase mask usage. So we found that legal sanctions, having a police person accompany the promoter, didn't increase mask usage. Signaling to others through signage didn't help. Verbal commitments didn't increase mask usage. Neither did text message reminders or even monetary incentives at a pretty high level. Neither did social rewards. What we did find is that this increase in mask wearing of almost 30 percentage points resulted in a decrease of COVID-19 by 9.5%. And that's when you look at serologically confirmed COVID-19. When we look specifically at surgical masks, we see a larger impact of 11%. And when we look at different age groups, we find that people over 60 had a about 33% reduction in their COVID-19. So really, really important. And this isn't because people over 60 are wearing a mask necessarily. This is because community-wide, there's a 30% increase in mask usage, and that is protecting older people. So really important. So based on these results, we said this is really important, and this is building on the evidence that we already have that masks are useful at a community level. Because of the timing, this is just when the Delta was coming into India. We actually had stakeholders from India, from Bangladesh, from other South Asian and other countries asking us to help scale up. How can their countries adopt masks and increase mask usage? So in conversation with governments across South Asia, also Mexico and Uruguay, we scaled up this intervention to over 100 million people. And I'll turn it over to Asif to talk more about that and what BRAC did in Bangladesh.
Great, thank you so much. It's 2:30 a.m. here, so if I sound incoherent, blame it on my lack of sleep. But this is, I think, a good segue towards what we did with the research. Can everyone hear me well? Yes.
Yes, we hear you.
Okay, excellent.
Thanks, Asif, for staying up so late for us.
No worries.
We appreciate it.
Thank you for inviting me. But at the same time, I think the Mushfiq's research came in such a great time, because when the first wave happened, BRAC was very much in a responsive mode. We were trying to do syndromic surveillance, working with the government and telco partners to ensure that community healthcare workers actually go to the doorsteps of potential COVID survivors. So to ensure that at-home services are available so that everybody does not go to the hospital. So then while that was going on, so that was around April, May, June timeframe of 2020, then we also started thinking around what we can do in terms of prevention. So mask wearing and hand washing was a big campaign that we started in 6th district around September of 2020. And we had mixed results. We actually studied that. We had mixed results, and we identified hotspots where we were going to give free masks and everything. But then when Mushfiq's initial studies, the results came about, that really gave us a lot of excitement. And then because it had a very specific sets of things that they did, and the numbers looked very, very promising, that from 13% to 42% increase. And then the fact that people actually continued for almost 13 weeks. So all of that were superbly exciting. So we grabbed that with both hands and looked at what were we not doing in our first pilot. And essentially the elements were the reinforcement, also the involvement of local influencers and national influencers. So we brought that in, and we sort of incorporated the norm model within our own existing system. So it was not exactly the copybook system, because I think the first thing was that to give that kind of blanket coverage in such a highly densely populated country, you would need a lot of money. So what the evidence that was generated from the Yale study was that really supported us to raise money, but clearly not enough. We only had about $6.5 million that we raised, but that was enough to go to the government and basically say that this is something that we really want to do. So the government then also was very, very interested. So they said, let's prioritize. And then they helped us identify 35 high-risk districts, because by then we were running against the clock, because what happened in India, there were very, very graphic images, and Bangladesh has three sides of its borders as India, and essentially everybody was really, really worried that this is going to happen in Bangladesh as well, and so we were running against the clock to not only by raising the money, but ensure that we get all our ducks in the row to roll this out as soon as possible. The other thing that we were doing differently in our pilot was that we were using cloth masks. Those were more expensive and also took a longer time to procure. So what the study gave us the idea of that high quality of reusable surgical masks. And so we could procure them very quickly. So within 4 weeks, we had the full operation up and running across half of Bangladesh. And within a span of 4 months, what we call, there's the community fort intervention, and they reached almost 80 million people in the country. So I think the first thing essentially was that so we prioritized, and then we ensured that we could do that at a lower cost. And at the same time, we sort of distributed almost 34.7 million masks across the country, and continued the reinforcement at the community level. And essentially, it also happened in phases. And so we also, not only the different components of norm model was used, but we also added some other elements to that, which we were using because we rather than using dedicated project stuff like it happened in the original study, BRAC's extensive community healthcare worker network and community healthcare volunteer network was utilized. So we could do other things as well. So what we did was that we did the syndromic surveillance. At that time, the vaccination arrived as well. So there was a lot of misinformation around vaccination. We did the vaccination campaign. We provided telemedicine support, and also the community engagement, and also capacity building of the community clinics, which were happening around the same time. So I think the research and evidence, if you ask me, was very, very pivotal to not only give us the confidence to go out and talk to the government and the donors, but at the same time, really also fine-tune the model that we were doing. And essentially, I think we really averted in Bangladesh as a result the wide-scale sort of peak that happened in India, and I think to a large extent we can credit this campaign that happened across the country with support from the government, researchers, and also implementers like us. Over to you. Thank you.
Thanks so much, Asif. And I think I was telling Mushfiq at the break that this conversation really reminds me a lot of a game my family has been playing since before the pandemic called Pandemic. And if you haven't played it before, I highly recommend it to you from ages 4 and up, even for adults as well. It's a cooperative game, and my son really hates to lose, right? He like very competitive, which is why we play cooperative games. And one of the things that I remember early on in the pandemic, right while we were all working together at very late hours of the night trying to solve some of these issues together, my son's like, why do we keep losing? You know, you either save the world or you don't in this game, is basically the way it works. And my daughter looks at him and says, well, she's 8. Well, you know, you have to solve a lot of problems at the same time, right, to win, and you have to do it really quickly. And I think that this team really did our best to do lots of that at the same time. And I think these two panels really demonstrate that. So now Jason's going to tell us a little bit about kind of what we learned in a broader context of these insights, and some of the policy implications and implications for future research, or some of the research we're working on right now.
Yeah. Okay. So thank you, Heidi. So I wanted to.
Are you on?
Can everyone hear me from my lapel mic, or no? Oh man, what was the point of that lapel mic? Okay. Can people hear me now? All right, excellent. So I just wanted to start by talking a little bit about what I think was the core element of this intervention that made it work, and how we're trying to adapt that to vaccines. So as Laura was describing, this was in some ways like a kitchen sink approach, where we tried multiple things to get people to wear masks, to sort of create social norms where people would know that other people expected them to wear masks. I think we're increasingly finding that if there was one core element of that, it was actually having what we call this in-person reinforcement. Actually having it be the case that in these public areas, if you're not wearing a mask, someone is going to come up to you and say, oh, hey, please put on a mask. So it turns out, this is not some shocking, deep finding of behavioral science, but if you politely ask someone to do something, it makes them a lot more likely to do it, especially if they can just do it right there and then. And so we're trying to adapt that to vaccines. You'll hear later about some work in Sierra Leone trying to make vaccines more proximate, making them available locally rather than making it that you have to go many miles to get vaccines. We're doing something similar in Bihar and trying to even go one step further to say, hey, we're going to knock on your door and vaccinate you right there and then. We should have results in a couple of weeks to understand how effective that was. We're also trying to combine that with incentives, potentially incentives for the people being vaccinated, as well as something that I actually think will be quite effective. We'll see if I'm right. I'm publicly stating that, which are the incentives for the people who are delivering the vaccine. Because when you go door to door, of course, there's a lot of logistical problems to solve. It might be that people aren't home. It might be that you need to come back at a different time. And if you incentivize the people who are going door to door, well, then they have an incentive to solve those problems. And I think if they reach people when they're home and say, hey, we'd like to vaccinate you right now, is that okay with you? I think actually a very large fraction of people will agree to that. I think the discussion of vaccines is often emphasized hesitancy and political resistance. And yes, especially in the United States, there are some parties that are really strongly resistant to vaccines. But I think there's a large swath of people where, regardless of how they answer in surveys, they're not so resistant that if a public health personnel comes to their door and says, hey, we actually think you should do this, are you willing to do it right now? That they'll be like, no, I refuse, I absolutely insist not. Some people will be like that, but not most. Okay, so we'll have results on that soon. I also just wanted to make a couple remarks about the broader policy landscape, where one trend that we've seen recently is I think there has been progress in overall global deaths. I think overall they've been declining. I think there's a number of reasons for that, including vaccines, including improvements in treatment, including natural immunity. We'll talk about masking in a moment. One thing I wanted to underscore was something that Saad had brought up earlier, which is that Paxlovid is an incredibly effective treatment. It massively reduces severe morbidity and mortality. And there should be more work applying everything we said earlier about vaccines to Paxlovid and trying to make Paxlovid more widely available in developing countries. Like right now, there are, of course, major issues with supply constraints. And we discussed a lot earlier about how different partnerships between the US and China, between many other countries, could help try to get around those supply constraints. That is an urgent issue, and people who are working in these areas should spend more attention to trying to scale up as rapidly as possible production of Paxlovid. Now, I actually think that in the very long term, vaccines plus Paxlovid can potentially get mortality to a low enough point that masks might not be necessary or are only necessary in exceptional circumstances. In most of the world, that's not the case yet. In most of the world, given current vaccine penetration and current availability of super effective treatments like Paxlovid, the return to mask wearing still remains fairly high. So I had one estimate in August of 2021, I estimated in the United States that it was about $50 per person day, about when applying that globally. So it's about 1/5 to 1/3 of daily wages is the value in reduced mortality risk of wearing masks. Now that has actually shrunk since then because the mortality rate has shrunk. So now we're getting closer to maybe instead of $50 a day, something like $10 to $12 a day, where it's still probably worthwhile. Now that's in the United States, where we have widely available treatments, we have widely available vaccines. In the developing world, you're talking slightly larger than that. So in places where we think that masks are useful, especially indoor places, especially crowded public areas, the return to mask wearing remains high. The last thing I would say is the return to mask wearing being high is a slightly different question from when do you want to have a major public policy effort to get people to wear masks. And I think, as Ashley was saying, what we have pretty good evidence of is that the return to those major public policy efforts are very high when you have severe COVID waves, when hospitals start to be overcrowded, when you see mortality ticking upwards substantially. In other times, it's good if people wear masks. The return to getting people to take vaccines, always very high. The return to getting more Paxlovid, always very high. And the return to initiatives, it's good to do initiatives to get people to wear masks, but they're especially essential during waves.
There we go. And with that, we'll wrap up and take some questions from the audience here. And I think there's someone online too, if you can share out some questions in a minute. There's one in the back over there. Yeah.
Does this work? Oh yeah, it is. Okay, work.
Can we keep Ashley and Asif up on the screen so we can, remember that they're there as well? Thanks.
Thank you for the presentation on your research on masks. I was just wondering, specifically, I think Michael mentioned this towards the end. So with the CDC's, relaxed mask guidelines recently, and there's been a tremendous amount of consternation over the wearing of masks in the United States, but I don't think it's just in the United States. Even in the research you highlight abroad, there's also a resistance to masks. So I'm just wondering, how do you see kind of the future of being able to reimpose mask mandates and encourage people to continue using masks as COVID becomes a longer phenomenon? And what are some of the complications in trying to encourage that behavior as people maybe become wary and want to move on?
Yeah. So the first thing I would say about that is I think it's an incredibly difficult question that people often have confident opinions about the right way to communicate science. And it's just something that we don't know a huge amount about. And so, public health authorities often get it wrong and other people get it wrong, but it's a difficult thing to do. The second thing I would say is I think that emphasizing, or at least my view on this, is that it's very helpful to emphasize what the return actually is, and that it's not something where people are like, oh, we want you to wear masks just so we can control you or something like that, but that there is a rational basis for these recommendations, which is that we're reducing mortality risk. At the present moment, the reduced mortality risk is pretty substantial globally. In the United States, it's probably a little bit lower than the global average, but it nonetheless remains the case that if you try to weigh the costs of mask wearing against the benefits from mortality risk, you find that if you're talking about things like mask wearing on airplanes or mask wearing in public transit, it's probably still worthwhile today. Now, is that going to be the case forever? Well, I'm not sure. I think once Paxlovid becomes more widely available, once other treatments are developed, I think that could easily not be the case. And so I think my personal view, again, with the important caveat that we don't know that much about the science of communication, is that it's good to emphasize that, look, in places where there are lots of deaths, if you are in a state where many people are unvaccinated, the return to mask wearing is extremely high. If you are in a place where vaccination rates are extremely high, where the best treatments are widely available, then the return to mask wearing is much more marginal.
Take your point as well. When we tried to share these results more broadly, they got taken up by certain outlets, and we tried really hard to get them taken up by other outlets. We even had some, faithful people on the team write for Christian outlets, and none of it got taken up, right? And so I hear your point that it's quite challenging. Asif, I'd wonder what you think about in the Bangladeshi context as well.
Yeah, I mean, I think what we saw in Bangladesh was, depending on the fear factor, when the waves came in, people really went over. It was much easier to convince people. But as soon as sort of it subdued, then people kind of were gone back to their business as usual. Because at this, I mean, you can also imagine that in Bangladesh, you have almost 87 to 88% people are mostly in informal sectors, and also it's not necessarily very practical to wear masks all the time because of the humidity and heat and all these things. So essentially, the natural default or sort of what really worked is this reinforcement, because we had religious leaders, we had people who were like the local political leaders who were very much telling them that this is what you need to do, you must do. and otherwise there was that fear factor that kicked in as well. So I think that played a role, but whether it's gonna continue over time, I don't think so. Right now, as I see that, you know, there is that potential threat of a wave coming in, but you know, that mask wearing is not quite there anymore. But surprisingly, what on the other side, on the vaccinations case, there was a lot of misinformation in the beginning for the first few weeks. But that quickly dissipated as well, because again, here in the case of vaccination, the local networks and also the religious leaders and others came really, really handy, because once they started talking in the same way, then there were absolutely people lined up. And you know, even like a few weeks ago, we had very, very long queues in the vaccination centers, so people were lining up to get people vaccinated, get themselves vaccinated. That was very, very interesting. I actually didn't think that the turnaround is going to be so quick in the age of social media.
I think we probably have time for one question online if there is, and one more in the room. We can take them at the same time and reply. No? Janai is saying no. Okay. All right, well then we will wrap up. Thank you so much for joining us for this panel, and Neela will let us know what's next.
Thank you.